Hello everyone, my name is Dr. Bukhari, and today our topic of discussion is how proteinuria develop in our patients with diabetes. To understand this question, first we need to understand the normal physiology of the kidney, and then we talk about abnormality, and we'll come to our answer. So this is JG apparatus. So I'm going to explain that a little bit. So we have afferent arteriole here, which eventually divide into glomerulus, and then we have efferent arteriole. We have this proximal convoluted tubule on this side, and then we have distal convoluted tubule. So normally blood flow from the afferent arteriole enter into the glomerulus, and some of the glucose will be filtered into the proximal convoluted tubule, but normally all the glucose will be reabsorbed. Normally all the glucose will be reabsorbed through sodium glucose co-transporter in proximal convoluted tubule, and no glucose will appear into the urine. So normally we have no glucose in the urine. But when we have patient with diabetes, what happens is the filtered load of the glucose will be very high in the proximal convoluted tubule. And not all the glucose will be reabsorbed into the proximal convoluted tubule, and some of the glucose will appear into the urine, which is called glucosuria. So proximal convoluted tubule, we have sodium glucose co-transporter, and these co-transporter will try to reabsorb maximum glucose as possible. And as they reabsorb glucose, sodium will also be reabsorbed along with glucose. When a lot of sodium get reabsorbed, the sodium delivery to distal convoluted tubule or to macula densa will decrease. And when sodium delivery to macula densa decrease, that will causes activation of renin angiotensin aldosterone system, which will eventually produce angiotensin 2. And we know that angiotensin 2 will act on efferent arteriole and causes constriction of the efferent arteriole. When this constriction happens, because blood will not be able to flow out from the glomerulus, and that will increase intraglomerular hypertension. That will cause intraglomerular hypertension because of chronic constriction of efferent arteriole. So chronic constriction of efferent arteriole because of increased production of angiotensin 2, that will cause changes in the basement membrane of the glomerulus. So chronic intraglomerular hypertension will causes in structural changes in glomerular basement membrane. So the first change, you can see this JG apparatus. So this is basement membrane. I'll try to show here that first there will be thickening of basement membrane. Basement membrane will get thickened. These mesangial cell will be expanded. There will be expansion of mesangial cell. Expansion of mesangial cell. So first change is thickening of glomerular basement membrane. Second, expansion of mesangial cell. And third, these food processes. There will be widening of these food processes. widening of food processes, and that will result in proteinuria, which is the earliest sign of diabetes. So that's how diabetes can eventually lead to proteinuria. If you cut it in short, when there's increased glucose in proximal columnar tubule, sodium will be reabsorbed along with glucose, and some of the glucose will go into the urine. But when we reabsorb a lot of sodium from the proximal columnar tubule along with glucose, there will be decreased sodium delivery to vecula densa, which will activate renin system, which will produce angiotensin 2. Angiotensin 2 will causes constriction of efferent arteriole, which will causes intraglomerular hypertension. Chronic intraglomerular hypertension will result in structural changes in the glomerular basement membrane. What are those changes? There will be thickening of basement membrane. Second, there will be expansion of mesangial cell. Third, there will be widening of the food processes, which will result in proteinuria. So this is how diabetes can cause proteinuria. Thank you very much. Have a nice day.